Good evening, everybody, and welcome to our TIF Talk tonight. Thank you for joining us. We're very excited today to have our special guest, Dr. Mohan Kulkarni. Dr. Kulkarni has actually been a guest of ours in the past, and we get to have him again. So welcome and thank you for being here today, Dr. Kulkarni.
Well, thank you. I'm very excited to be here. I know I've enjoyed these before, and they're always very stimulating and exciting. Thank you for having me.
Thank you. So as a reminder to everybody, this is a live event. At any time, if you're interested in asking Dr. Kulkarni any questions, you can go ahead and type it into the chat section, and we will do our best tonight to answer all of your questions. My name is Andrea Millers, and I'm with Endogastric Solutions. I want to give you a little bit of background of Dr. Kulkarni. He is a thoracic surgeon, and he practices in Jackson, Michigan. He is fellowship trained and board certified in both general surgery and thoracic surgery. Dr. Kulkarni's research interests include robotic and minimally invasive surgery, and his practice focuses on the treatment of lung cancer, da Vinci lobectomy, and gastroesophageal reflux disease. So again, we can't thank you enough for being here tonight, and we're looking forward to talking to you a little bit more about GERD and the TIF procedures. So thank you, Dr. Kulkarni, for being here.
Thank you for having me.
So let's go ahead and start talking a little bit more about GERD. If you can explain what is GERD, what are the types of symptoms potential patients could be feeling if they have GERD, and the typical symptoms or possibly the atypical symptoms. Just if you want to go and explain those for us, that'd be great.
Awesome. So GERD, or as we like to call it, GERD, gastroesophageal reflux disease, is a condition when contents of the stomach leave the stomach and come into the esophagus. And that causes burning sensation, and because it's near the heart, we often refer to it as heartburn. But that's the least of the issues. Reflux itself, acid coming up into the esophagus, can cause a lot of problems. Stomach is well endowed with defense mechanisms for acid because acid generally resides in the stomach. But when acid leaves the stomach and comes into the esophagus doesn't have defense mechanisms against acid. So it can literally burn through the wall of the esophagus. It can come up all the way into your mouth. It can go into your lungs. It can affect your windpipes. It can affect your voice box. So it can effects that are not good for your body.
Thank you. I appreciate that. So what do you generally recommend patients to do to manage their GERD? I know you're a thoracic surgeon, so are you seeing the patients initially, or are they coming in as a referral to you?
Well, there are few patients that refer themselves directly to me because they've heard about our program. They've seen these chats. They've been on the internet, and so they come across my site and come to me. But a lot of people come from their primary care docs. A lot of people come from pulmonologists, lung specialists, because they've developed adult onset asthma, for instance, and everything's been ruled out except acid, which has come out from the esophagus and gone into their lungs and caused them to have wheezing or asthma. I get referrals from ear, nose, and throat because patients developed a hoarse voice or sinus issues or polyps on their cords. These are all related to reflux and acid injury. And you can just constantly, I've had ear, nose, and throat doctors go in time and again, remove polyps from the vocal cords. They finally just say, you need to get your acid fixed before I take any more polyps out of your cords. So I see internists, pulmonologists, and ENT doctors sending, as well as gastroenterologists. I mean, gastroenterologists are the ones that come across reflux commonly. They scope people. They see structural defects in the stomach and esophagus, like hiatal hernias. They see damage to the esophagus when they see scopes. They biopsy and look for sinister conditions in the esophagus, like Barrett's esophagus, which can be a premalignant condition caused by reflux. And if Barrett's is not treated properly, it can move to esophageal cancer, which is one of the worst complications of reflux.
So I was unaware of the polyps from the ENTs. Is that directly correlated from acid reflux?
Yeah, so acid injury to the cords can create an inflammatory response, which can turn to polyps. I've had people that are in the choir who have stopped singing at church because reflux has made their voice hoarse. And so they come and see me. We fix their reflux, and they've been able to join the choir again, much to their delight.
Wow, that's crazy. So as far as managing their GERD, there's a lot of lifestyle modifications people can do, or food aversions, initially. But at what point is it important for a patient that's been suffering that they go see someone like you, a specialist or a GI, to help them with their reflux?
So, we've all had those late college evenings where we've had pizza and beer and we get reflux. So everybody's had some sort of heartburn in their lives. But about 10% of the population, which is 30 million people, maybe 35 million people in the US, have reflux as a condition, which means they have at least one severe episode per week. Any episode that happens at night where they wake up with acid rushing into their esophagus, or they're startled awake because they feel like they're going to choke on their acid, that has to be seen right away, because it can lead to aspiration pneumonias and other dangerous conditions. So if you're having one major episode a week, I think it's worth seeing a doctor, a gastroenterologist, or a physician who can help you with that. Yeah. And when you have reflux, 35 million people, I usually start out by saying, look, you got to do some changes, lifestyle changes. I tell people to have smaller portions, perhaps because a full stomach tends to reflux more. I tell them not to eat 3 hours before bedtime, not to drink 1 hour before bedtime, and avoid things like smoking, alcohol, chocolates, any fatty foods, anything that contains a lot of onions or garlic. People are well aware of these by the time they come to me. They said, Doc, I've tried everything. I just can't get control of my reflux. But those are some of the weight loss, some of the things that are easy to do. Well, maybe not easy to do, but easy to tell people to do.
Right. Fun stuff they have to cut out, right?
No more nights out.
No more nights out, right? So let's talk a little bit about what options are available today to treat GERD, if you could, please.
Yes. So in the past, we've had this idea that they have to go to an internist, and heartburn after what we call behavior and diet modifications hasn't worked. So then they go to an internist, and then they usually get put on. In the old days, it used to be cimetidine, and then it was Zantac, then it was Prilosec, then it was Protonix, then it was Meprazole, and newer ones like Nexium. So what they do is they suppress your acid production. So your acid has zero acid. So your stomach has zero acid production if you take these very strong medications. And unfortunately, that can have some side effects that are not desirable. Acid was obviously put there for a reason. It helps you kill bacteria that you swallow, and everybody swallows bacteria when they eat. It helps you absorb calcium, because calcium is important for your bone health. And if you take these kinds of medications called PPIs, they can cause osteoporosis and bone fractures in the elderly. So I've known people who've been on PPIs for like 20, 30 years. They also get a higher risk of aspiration pneumonias and C. diff colitis. So there's a lot of literature out there drug interactions with other things like Plavix if you're on heart medications. So there's a lot of reasons not to be on PPIs forever. If you look at the label, they say don't take for more than 6 weeks. And if you are on it for more than 6 weeks, consult your doctor. So I think in my mind, the biggest change in my mind I had to think of is offer them an alternate surgery, offer them surgery as an alternative rather than leave surgery as a last resort. So clearly there are young people out there who are 30, 40 years old. You don't want to put them on PPIs for like 70 years. That's not practical. And it doesn't even solve the problem. The underlying problem is the valve at the bottom of your esophagus is not working well. And it normally when you eat, this valve opens up, it takes all the food into the stomach, and then it closes. It stays shut between meals. But if you have a leaky valve, you can have refluxing of acid and food into your esophagus. So by doing PPI therapy, all you're doing is suppressing acid. You're still getting reflux, but maybe not acid. So I think the best thing to do is treat what I call the plumbing problem, the underlying problem, which is the valve. And we have surgical alternatives to that. Classically, it's been this thing called Nissen fundoplication, where you take the stomach and wrap it completely around the esophagus and fix the hiatal hernia. That used to have a safety profile that I'm not happy with because a lot of people end up getting gas bloat and can't swallow thick breads, can't swallow meats, can't burp, can't throw up, get severe gas bloating after a meal. So you're really trading one problem for another. You got rid of your reflux, but now you're dealing with all these other side effects that can last a long time. So a nice way to take care of this problem is to fix the valve but not make it too tight. And the endogastric solution TIF procedure, or transoral incisionless fundoplication, allows you a very good safety profile where you can keep the acid where it belongs and keep the food where it belongs in the stomach. But it also allows for easy passage of food from the esophagus into the stomach and not have all these gas bloat issues or difficulty swallowing issues.
Right.
Great thing about transoral fundoplication or TIF procedure is that you can do it without incisions. You can insert a scope into your mouth and into your stomach with you asleep, and then we can insert the device over the scope and kind of wrap the stomach around the esophagus internally without making cuts on your belly. Now, having said that, if you happen to have a hiatal hernia, that cannot be reached through the stomach. So what we've done is designed a combined procedure where we do robotically, where you use tiny holes and use latest robotics to fix the hole in the diaphragm, which is the hiatal hernia. And as second part of the procedure, we provide the TIF component, which is done through the mouth and the scope. They're both done at the same time. Operation lasts anywhere from 2 to 3 hours. They're in the hospital 23 hours, and then they go home.
Thank you, Kulkarni. In your experience, what's the percentage of your patients that actually do also have a hiatal hernia versus just being able to just treat with the TIF only?
So there's a small percentage of people that only have a valve problem, which is the weak valve and no hiatal hernia. I would say 80 to 90% of patients who come with reflux have a component of hiatal hernia, and then they have a weak valve both. So I've done well over 500 of these now where we robotically fix the hiatal hernia, and then we also do the transoral fundoplication or the TIF procedure at the same time.
Fantastic. Thank you. We do have a couple of questions that have popped up, so I'm going to ask some of those questions before we continue. TJ is saying sensitive to smell. So I'm assuming he's asking, does GERD or acid reflux have a link to sensitivity of smell?
That may be a separate component, but what he may be experiencing, TJ, is the acid coming all the way into your sinus and nasal passages. A lot of people are not aware when reflux happens at night because they're asleep. Their conscience is not alert. So then when you lay down, you lose gravity as your friend, and the acid can come trickling into your esophagus and up into your nasal passages. That might make you sensitive to smells. That's the only link I can think of.
Okay. Thank you.
Sure.
Tara is asking, is there any link between GERD and IBS?
So irritable bowel syndrome, or IBS, is a condition that affects the whole GI tract. It can come from the esophagus to the small bowel to colon, and sometimes it's associated with diarrhea, sometimes it's associated with constipation, abdominal pain, bloating. So in my experience, when you have irritable bowel, it's a independent problem. And I usually tell people to steer clear of surgery for reflux if you have a documented irritable bowel syndrome, because sometimes it's made worse.
Okay, interesting. Okay, someone was asking, how quickly did that patient recover or return to the choir, the example that you talked about?
Well, that I usually don't. I mean, she was practicing home singing like within a week of surgery, and in about a month she went back to choir. Fantastic. We have this typical restrictions after surgery that are some people have raised their eyebrows, if you will, because I tell them that they have to be on a liquid diet for 6 weeks, and they just kind of stand back and say, "Whoa, liquid diet." But I go on to tell them that I've tried it myself. I also tell them that I haven't lost anybody on a liquid diet. You can get all your nutrition on a liquid diet. If you want to chew on something, you can chew on ice. And there are interesting things on a liquid diet, such as wine or ice cream or smoothies or protein shakes, milkshakes, and pretty much anything that's in your pantry, as long as you can put it in a blender and suck it through a Dairy Queen straw, you're good to go.
That was one thing I remember vividly from the last interview I did with you and your two patients that you had that were fantastic, the sisters. We should bring that up again sometime and share that with the Facebook group. It was such a fantastic story about them, and that was one of the things that stood out when they told me the hardest part of the TIF procedure was the diet. And I know that you have a very strict protocol on your diet, the 6 weeks with liquid, while most doctors say about 2 to 3 weeks, right? So, but do you think that it has something to do with the successful outcomes of your patients because of that liquid diet for 6 weeks?
I think it has a lot to do with it because I have a captive audience. I'm the only surgeon in town. So if things go wrong, they come back to me, and our recurrence rates are very low. We have over 90% success rate, and our recurrences are low. And I can kind of pinpoint some of the reasons why they recur, like if they've been in an accident where they've had sudden deceleration of their stomach, if they binge ate, if they started eating solids prematurely. I tell people, you don't want to walk on wet cement. You got to wait till the cement dries before you walk on it. So it takes about 6 weeks for the repair to heal and cement together. After that, you can introduce solid foods across the repair. So just take on liquids, and after a couple of weeks, it kind of becomes second nature. I've had couples do it together as a romantic thing, if you will. And they support each other. These sisters we talked about, like I did the procedure on one of the sisters, and she was so happy with it. Then she kind of went and talked with her sister that they hadn't talked health for a while, and then realized that, you were suffering from very similar symptoms that I have been suffering for years. And why don't you consider talking to the Kulkarni? So she came in, and it was cute because they helped each other. The sister helped her make liquid meals after surgery. She helped them. It's very little to recover. We just tell them not to lift anything over 10 pounds, and then stay on a liquid diet for 6 weeks.
I love that story. Tell me a little bit more about what patients could expect the day of the procedure. Do they spend the night? Does it differ if they have a hiatal hernia or just the TIF procedure? What are the expectations for the actual procedure day?
Very good question. Before they come for surgery, and we've had them worked up, if you will. We've had their scope done. We document whether they have the hiatal hernia or not. We sometimes also will put a pH probe in to confirm that they're suffering from reflux. And once they've had their workup done, they come for surgery. A lot of them are from out of town. So we tell them to stay on a low-fat or zero-fat diet for a couple of weeks. I tell them to let that liver shrink down a little bit, put that liver on a diet, and then it's easier to lift the liver out of the way without hurting it. And the hiatal hernia, if you will, is just under the liver. So the protocol is the same whether you're going to get a pure TIF procedure or if you're going to get the robot hiatal hernia repair combined with the TIF. They come in the day of their procedure. We put them to sleep. We do their repair. We tighten their valve. And they stay in the hospital overnight. The most important thing I think we keep them in the hospital for is to control their nausea. Like any anesthetic, it has a susceptibility to make you nauseous. So we want to control their nausea. We don't want them throwing up after surgery. So we keep them in the hospital, and we have this huge protocol of multiple medications to do their anti-nausea control. And so we hardly have anybody have any nausea, vomiting after surgery. The next morning, they start on a liquid diet, and after a couple of meals of clear liquids, they're on their way home. So it's a 23-hour admission.
Fantastic. So we do have a couple of more questions I do want to make sure we get answered. From Asha, why do I get food coming to my mouth? I'm on a PPI for almost 5. She's been on a PPI for almost 5 years, but she's still getting regurgitation, basically.
Okay, Asha. So the PPIs are suppressing acid production in your stomach. It's not doing a thing for the valve pressure. And remember, I said the valve at the bottom of the esophagus is the primary problem. It's not working well. It's loose, and it's supposed to remain closed between meals, and yours is loose so that when you lay down at night, gravity is not your friend anymore. That food will come trickling into your mouth as you lay down. So you can sleep with the head of your bed elevated and perhaps not eat for 3 hours before a meal, and that might help. 3 hours before bed.
Yeah, so there's another question here asking, does the PPI stop, does it help with regurgitation? And you just answered that perfectly, right?
Yes. Acid is suppressed, so it's acid that's not coming up anymore, but it might be bile, it might be food, it might be other stomach juices. So things are still coming up. They are just not as hurtful as acid is, so you feel better even though the injury is ongoing.
Right. Another question from James. I get a bubble under my breastplate. I'm on a cocktail of non-PPIs that has helped, but it is possible I could benefit from this treatment. Sometimes when I can't get the burp up, it will cause me to gag. So would this procedure help me?
So the bubble might be gas trapping. There might be a component of stomach above the diaphragm. You may have a hiatal hernia. So when you swallow, we all swallow air when we eat because we eat in a hurry. And then the air part might get trapped in the stomach above the diaphragm. And that's what's causing you to feel like that bubble under your breastplate. And so just kind of relearning how to eat without swallowing air or getting your hernia fixed up that problem.
Thank you. Perfect. Another question, is regurgitation and belching with regurgitation a common complaint with your patients? Does the TIF solve this issue for most of your patients?
So there's regurgitation, and then there's belching, and then there's inability to burp. So when you have a very tight repair, such as in the old days with the Nissens, the air that you swallow gets trapped in your stomach and is unable to come up, and it causes you to have gas bloating, and you can't burp. We all belch once in a while, and the ability to belch actually to relieve pressure in the stomach is a good thing to have. And so with the TIF procedure, you're not going to get acid reflux, but you have the ability to get rid of the air and feel better. And if you're belching and bringing up acid at the same time, your valve might be messed up, and you probably should get that fixed.
Yep, perfect. What types of, I think you mentioned a little bit about workup, but maybe you can explain the different types of testing or diagnostic testing someone would get in order to determine if they were a candidate for an anti-reflux procedure or a TIF procedure.
So the most important of them, where a GI doctor or a surgeon like myself will sedate you, put you to sleep, and then look down into your esophagus. We're looking for evidence of injury. We're looking for damage to the wall of the esophagus. We're looking for presence or absence of a hiatal hernia. And we're looking for other things that might be mimicking reflux, such as an H. pylori infection in your stomach, or something like a gluten allergies in your small bowel. So we look for all those things. We look for polyps. God forbid, there might be a precancerous condition or cancer. We look and biopsy everything that looks unusual. So the scope is a very important thing. If the diagnosis of reflux is in question, if we're not sure if the patient has reflux or not, then sometimes we'll put a pH probe in the esophagus. That's called a Bravo probe. There's no wires attached. It's a wireless device. We do it at the time of endoscopy, and its sole purpose is to determine whether there's any acid leaking into your esophagus. You carry this little pager device, and it's a Bluetooth technology where the pager talks to the probe, and it documents how much acid is coming in a 48-hour period. So we have norms for people, what we consider normal reflux, and then we can compare your scores to the normal population and tell you whether you have reflux or not with over 96% certainty. There are other interventions or testing we might do, some motility tests to make sure that reflux is what you have and not a muscle disorder of your esophagus. So those are some of the things we'll do, and then we'll have a consultation, put all the data on the table, and give them options on whether they want to continue the way they're doing or whether they want to get their valve fixed.
Perfect, thank you. Aisha is said thank you, first of all, for answering her question, and then she's asking, am I a good candidate for TIF? I am 67 years old.
You are just a young thing, Aisha. You should get it fixed. You don't want to face this problem for another 40 years.
That's a good point. Good point. So another question, my friend had a Nissen 2 years ago and has experienced difficulty swallowing. Does TIF cause the same thing?
Very good question. The Nissen creates a tighter valve and a 360 or a full wrap of the stomach around the esophagus, whereas the TIF procedure does a partial wrap or not as tight a wrap around the esophagus. So it has a better safety profile. You can burp if you want. You can throw up if you want. You can eat meats and breads. They're not going to get stuck. So these are some of the differences that I've noticed in my practice.
So in your practice, you used to, did you do Nissens prior to the TIF procedure?
The very first or second year of my practice after coming out of training, yes.
Okay. And then now that you do the TIF procedure, what is your percentage? And I know not everybody's not every patient's going to be a candidate for the TIF procedure and or the Nissen or any other of the other GERD treatment options, but because of the side effects that your patients have had from the Nissen, are you doing a lot less Nissens now than you were before?
I personally don't do any Nissens at all.
Okay.
But being a thoracic surgeon, I see a variety of disease. So I get the very large hernias called paraesophageal hernias, where not just the stomach, but perhaps other contents of the belly have gone up into the chest. Well, transoral fundoplication or TIF procedures are not a good idea for those. We bring all the contents down into the belly robotically, and we fix the hilar hernia or the hole in the diaphragm, and then we might do some sort of a wrap at the time. But if you have a hilar hernia that's anywhere from 3 to 5 centimeters, and your typical refluxer that's documented with a pH probe, I will offer them a combined procedure, which is fix their hilar hernia robotically and then do their TIF at the same time. If you don't have a hilar hernia, then I'll offer them a pure TIF procedure where we just fix the valve. And this is done endoscopically without any cuts on the body.
Fantastic. Now, I did hear you mention that some of your patients are from away from your city. You know, they're traveling potentially. With that said, are you currently, because of you know, COVID and everything going on right now in the world, are you doing telemedicine right now, Dr. Kulkarni?
Very good question. So people that are coming from out of town, which we have a lot of, we try to minimize their visits to us because of COVID fears, but also it's a hassle to travel 2-3 hours. So the first one might be a telemedicine visit where we talk about your symptoms. If you've had an endoscopy done, we ask that you fax over the pictures and the reports to us so we can review them and don't have to repeat them. We also will look for what's called a pH study. And if we're uncertain as to your workup, then we might ask you to visit us once, where we do all-in-one kind of thing, where we'll examine you, look at you when you come in, talk to you, get your full history, and then we might scope you while you're here. As you leave, we might put a pH probe in your esophagus so that you take that home and you mail in your pager, and then we can determine for sure if you have reflux or not. And then we can do another phone interview and talk about whether you're a surgical candidate. So they don't have to come in person.
That's
if
great.
They are going to have surgery, they'll travel that second visit and have the surgery and then leave the next day.
Perfect. Thank you. Can you talk a little bit about, you know, the safety of this elective procedure, if you will, in these times? There's a lot of patients that I hear are concerned about going into a hospital or, you know, the fear of potentially catching COVID, or how do I, you know, what are you guys doing, and what types of protocols does your hospital take to make these patients feel comfortable and safe? And I think, you know, another physician that I interviewed a couple months ago was saying, you know, you don't have to wait and keep suffering. Now's the time to come in and get this fixed. But I think it's still that fear of, you know, is it safe for me to come into a hospital to get an elective procedure? So maybe you can speak to that a little bit.
That's a very good question. And, you know, as was discussed, that Prilosec or omeprazole might even increase your risk of getting infectious disease, such as COVID. So I'm not sure about the science on that, but I could see that happening. So we have safety protocols that affect employees. So we've minimized traffic in the OR. Everybody who comes into the hospital, if you're working there or not, gets screened. We ask 4 or 5 standard questions. We also take their temperature, and we ask them about their exposure. And then we let them into the hospital if they're safe. The team in the OR is typically masked to the hilt. They have eye protection, face protection, and N95s. We have very definite cleaning protocols between cases where we sterilize everything. And we did shut down for a while when COVID was surging in our area, just so we could have the resources to take care of the COVID patients. But we have ever since then, we did open up our operating rooms because we can't let these people suffer forever either. We can't let cancers go untreated. So there are consequences not to treat elective patients. And so we have developed very, very safe protocols, and we're up to speed now. We're up to 100% of what we were doing in terms of volume before COVID hit.
Fantastic. Wonderful.
And we separate the COVID patients on a separate part of the hospital versus the surgical patients.
Yeah, that's great. I know the other physician said you're probably safer coming into a hospital than going grocery shopping.
Or going to a bar, yes.
Yeah. We talked about a little bit about, you mentioned esophageal cancer and Barrett's, and potentially what could happen if you prolonged your reflux or your heartburn. Can you talk a little bit about that and why it's important to see a doctor about your acid reflux if you truly have GERD, and or what potentially could occur if you don't take care of it, if you will?
So there is something to be said for self-isolation and social distancing, but a lot of that has led to not doing the preventative measures that doctors are supposed to do for their patients. We need to have you, if you have a history of smoking, you may qualify for lung cancer screening. You need to have your CAT scans done so that the cancers can be picked up early and potentially cured. If you have reflux, you definitely need to have a endoscopy done to make sure you don't have this precancerous condition called Barrett's. If you're not coming in, you're not getting the screening done, you're not getting the scopes done, you're not getting the CAT scans, you might be doing yourself a disservice. So we have learned to do it safely, and you should definitely come in to get a colonoscopy, for instance. If you're 50, or if you have a family history of cancer in the colon, then you might have to do it even before the age of 50. So all these things got kind of left behind or weren't done in a timely manner because of COVID, and we've learned that also has consequences. So we've learned to do it safely, and it's better to talk to your primary care doctor and start doing these screening things.
Perfect. Thank you. We have one last question that I want to get to. Aisha's asking, is the TIF procedure covered by Medicare?
So yes, we do have coverage with majority of the insurance products in the U.S.
Perfect. Okay. And then the last question is, I've had the TIF done and had a recent endoscopy because of chest pain. The doctor said my TIF is good, but may be too tight. So she's asking, should I have it loosened? But she's afraid that her acid reflux would come back if she did that. This is from Teresa.
Teresa, that's a very legitimate concern. You've had your valve tightened so that acid is not coming into your esophagus. But then you may have had some scar formation where it's not allowing the acid, not allowing the food to pass easily from your esophagus into your stomach. So there are gentle ways of stretching the scar and not undoing the repair. We've done that occasionally. That's helped people swallow better.
Perfect. Thank you. So any last comments that you want to make? I know, we're coming up on November and it's GERD Awareness Week, the week before Thanksgiving. In addition to that, next month is Lung Cancer Awareness Month. One of the things we like to do, or what we're doing with these TIF Talks, is raising awareness about GERD and the TIF procedure. Is there any last comments or things that you want to leave to these potential viewers that are watching, or those that are suffering from GERD or acid reflux? Any last recommendations or comments that you'd like to leave?
Thank you. A couple of comments. I know Thanksgiving is a perfect time to talk about reflux because we all want to have that turkey and go into the coma and not suffer from reflux. So it's important that we eat well, eat smaller quantities, and not lay down right away after eating. Make sure you're up for 3 hours and not eat 3 hours before bed. Consider having the procedure done, or at least have a scope done. If you are suffering from reflux, this is a great time to do it. People have some time off, holidays, and we're gladly accepting patients around that time. The other thing is, you mentioned lung cancer awareness. It's my one of the things that's been my calling is to take care of lung cancer. And it's really sad when patients show up late in the game, higher stage, and it's harder to treat them or cure them. So if you do have a relative, or if you yourself have had exposure to tobacco, it's one of those conditions where sometimes I feel like there needs to be more sympathy than we as a society are allowing to give it, because the feeling is like, well, you did it to yourself. But whatever happened is in the past. If you have had exposure to tobacco, please consider getting a screening CT done, because lung cancer awareness is November, and it's better to treat it early and catch it early.
Perfect. Wonderful. Well, can't thank you again for joining us this evening. Viewers that are watching, if you're in the Jackson, Michigan area, or close by, 2 to 3 hours away even, you are welcome to find Dr. Kulkarni and schedule a consult with him. You can even do it telehealth. But if you're not in the area, you can go to gerdhelp.com and you can put your zip code in there. There is a physician finder, and you could find a physician near you that offers the TIF procedure and other GERD treatment options. So thank you again, Dr. Kulkarni, for joining us this evening. We really appreciate it. I know the people that have asked questions, they're saying thank you as well, and they really appreciate it as well. Everybody, I hope you have a great evening. And thank you again, Dr. Kulkarni, and we'll catch you next time.
Yes, thank you for giving me the opportunity to speak.
Fantastic. Thank you. Have a good night.
Thank you.